Hello, Dr. Nader, can you hear me?
Hello, welcome to our Zoom meeting. Welcome to our weekly Zoom meeting. Today we will discuss four topics. Dr. Malaz and her team will be presenting. Please, Dr. Malaz, when you are ready. Thank you.
Good evening, everyone. It's a real pleasure to welcome you to today's research fellowship session. This fellowship represents a shared space for curiosity, critical thinking. We are honored to be working under supervision Dr. Nader, whose guidance continues to shape this fellowship into meaningful and impactful journey. My name is Dr. Malaz Salah, and I will be moderating today's session. Let me briefly walk you through today's agenda and our. Can you hear me well?
I don't know for others, but for me, it's like, yeah, on and off. But I don't know for others.
Okay, let me just check my connection.
Now it's good.
Okay. Good evening, everyone. It's a real pleasure to welcome you to today's research fellowship session. This fellowship represents a shared space for curiosity, critical thinking, and innovation, where clinical experience meets research-driven solution. We are honored to be working in the supervision of Dr. Nadir, whose guidance continues to shape this fellowship into meaningful and impactful journey. My name is Dr. Malaz, and I will be moderating today's session. Let me briefly walk you through today's agenda and our speakers. We will begin with a clinical important topic, dizziness in older adults, presented by Dr. Almar Hassan Ahmed. Next, we will move into an innovation-focused discussion, vacuum technologies that destroys clots, which I will be presenting. After that, we will shift toward practical experience with tips and tricks, presented by Dr. Ayah Abdullah. Then we will explore an exciting application of medical robotics, magnetic robot for kidney stones, presented by Dr. Sara Ali. Finally, we will conclude with updates on our ongoing projects. Each session adds a unique perspective to our fellowship, and together they reflect the multidisciplinary spirit of our work. So we will start with our first topic. It's my pleasure to invite Dr. Almar Hassan Ahmed to present on dizziness in older adults. Almar, please go ahead if you
Yes,
are ready.
thank you, Dr. Malaz. Am I heard?
Yes.
Yeah.
Okay, first of all, I would like to say that I'm really grateful for this opportunity to join the program. It's my first time. And thank you, Dr. Malaz, for orchestrating this. And I'm very excited to share the presentation that I prepared today regarding our topic, which is understanding the dizziness in elderlies. So the reason why this topic is actually really interesting and important is because we really have so many factors that contribute to dizziness in older people. And in this particular presentation, we're going to be discussing how can we recognize it, what are the causes, and what is the approach that we're going to take regarding the treatment and regarding the investigation as well. So is my screen clear?
Yes.
Can everyone see my
Yes.
screen?
Yes.
Okay. So first of all, why does it matter? Why are we talking about this? It's because dizziness is really a geriatric syndrome. And we say it's a syndrome because you rarely find just like one smoking gun. It's usually a perfect storm. The patient has a little bit of arthritis, slightly poor vision. So, long story short, it doesn't really have one particular thing. It's really just a combination of multiple things. And it's common. So, the prevalence is 4% to 30% in older adults. And it's also most commonly happening to women. And it's also complex. As I said, that it's multifactorial. So over 50% of the cases have multiple causes, and we're going to see that in a while. And it's also dangerous. Obviously, we're always scared of the elderlies feeling dizzy and falling and having fractures that might potentially be very bad for their health. So we also have fear of falling and depressive symptoms. So we're going to see the characteristics of dizziness. Usually this kind of dizziness resolves within days to several months. And of course, it depends if it's chronic or recurrent symptoms. And we have multifactorial etiology that usually happens, as we said, it's a syndrome. So commonly associated with, for example, postural hypotension, anxiety, and depression, a lot of medication. So as we know that elderlies usually have this habit of keeping a bag. It's kind of like a salad of medication, and they kind of share it with each other, or they take a lot of medication, too much of it, too little of it. So all of these can also be factors that contribute to that. So that's why we need to have a multifactorial assessment as well as an intervention strategy, depending on what is the type. But before that, it's important for us to understand dizziness, the types of dizziness, and how can it come as. So it can be acute or chronic. Acute is independent of age, and usually it's a disorder of like one particular system. For example, you have acute vestibular neuritis, cerebrovascular ischemia, cardiovascular disorders resulting in hypertension. But for the chronic ones, these are the ones that we kind of like don't know how to manage. Ongoing for greater than 1 to 2 months, and it's more common in elderlies. And as we said before, that it has multifactorial etiology. That's why we need to approach it in a particular way. So the diagnostic framework, in order for us to know how to approach it, we need to know its types and recognize it when a patient comes to us. So we need to ask beyond the dizziness. There are 4 types. We have vertigo, presyncope, disequilibrium, and then when all these 3 don't fit your criteria, we go to nonspecific or mixed. So we're going to look at each and every one of them, what they are, and how can we approach them. So for vertigo, it's usually episodic spinning or rotational sensation, and they have multiple causes. We're going to see them. Presyncope is really anything that has to do with like the blood flow. So when someone tells you that, oh my God, I feel like I'm fainting, or I feel like I'm going to lose consciousness, we're going to think of presyncope. Disequilibrium is usually a sensory problem. So imbalance only on standing or walking. And as I said, if all these 3 don't fit, we go to nonspecific. Usually they're going to tell you something else other than the room is spinning or I feel like I'm fainting. They're going to tell you, I feel like I'm floating, or like I feel woozy. So let's start with vertigo. Usually they're going to come to you and tell you the room is spinning. It's either subjective or objective. They can tell you the room is spinning or I'm spinning. And there are 2 causes. The one that we really worry about is the central causes. So the peripheral causes like BPPV, which is basically episodic inner ear disorder. So usually it's triggered by the head position. Someone moves their head too fast, they roll on the bed or something. The debris basically goes from one part of the ear to the other, and because of that, it makes them feel like the room is spinning. And it usually lasts for a couple of seconds. And then afterwards, we have the Meniere's disease, which is idiopathic inner ear disorder. Now, this is kind of a triad of a couple of things. You have tinnitus, hearing loss, and severe vertigo. And then we have the central causes like cerebrovascular ischemia and acoustic neuroma. At the end of this presentation, I actually have a couple of cases wherein we can showcase that. So BPPV is really the most common cause. It's mechanical. So the otoconia kind of gets lost in the semicircular canals. I think we could see here the anatomy of the ear. It's supposed to be here, but then it goes somewhere else. And because of that, it's responsible for actually sensing the gravity, and it gives the sensation that the room is spinning. Unlike the Meniere's disease, which is different, it involves hearing loss, tinnitus, and feeling like your ear is full. So that is the thing about vertigo. The type 2 and type 3, we have presyncope and disequilibrium. So for presyncope, it's a perfusion issue, really. What happens is that the patient is going to come to you and they're going to tell you that they feel like as soon as they stand up or after they eat, they feel like they're going to pass out. So that's why we have multiple causes for it. We have, for example, orthostatic hypotension. Orthostatic hypotension is usually when you have your patient stand up maybe too quickly, they're going to start to feel like they want to faint. And the definition for this is really the drop in systolic arterial blood pressure of at least 20 millimeters mercury, or drop in diastolic pressure from standing up when they're sitting and they stand up too quickly. So it's either that they stand up too quickly or after eating they feel like they want to pass out. These are basically the things that we can relate to pre-syncope, as well as arrhythmia and cardiovascular disorders. The reason why we need to know what each and every one of them present as is in order for us to be able to approach it later on with the treatment. So this is why it's important to say, okay, this is pre-syncope, or this is disequilibrium and such. Disequilibrium is usually a mechanical or sensory issue. So usually when someone has a problem with, proprioception, or they have a problem with their visuals, for example, cataract or such, it can actually disturb their equilibrium. For example, you have peripheral neuropathy or proprioceptive disorders, any vision problems, any musculoskeletal or gait disorders, like, for example, Parkinson's, or if somebody has arthritis and such, it can interfere with that as well. Now, if none of these fit and they come and tell you something weird, like they feel like they're floating and such, we're going to think of others. And usually the most common thing that we think about is psychiatric causes. So a patient might actually have depression or anxiety, and that's the reason for their dizziness. And we're going to see a case for that and how it actually presents. But usually, as we said, that a big culprit for these kind of dizziness, especially with elderlies, is the medication. They have a sedative medication that they take daily, and that might actually cause the dizziness to happen. So we have sedatives, which dampen the CNS, antihypertensives. If they take it, for example, sometimes they forget and they take another one, and next thing you know, their blood pressure is too low and they feel like they're going to pass out. Antihistamines, they usually do a suppression, as well as NSAIDs. Some of them are ototoxic for the ear, and it might cause for dizziness in elderly people. So what can we do about that now that we know the types of dizziness and what might cause it? We're going to do an examination. So we always go back to the basics, which is take history. It's very important to take history because every single cause has a particular thing that has that light bulb go off in your brain. So that's why we need to let the patient describe the sensation without you suggesting the words. So you don't suggest for them. You let them just speak with their own words. And they even teach us that in med school, wherein you write down exactly what the patient says. So, whether the dizziness is characterized by spinning or imbalance or unsteadiness, how frequent, the duration, if there's any other symptoms associated with it. For example, hear loss, ear fullness, as we said in Meniere's disease. And what medication are they taking in case they have medication that is actually, as we said earlier, a culprit. And we also want to ask them if it's affecting the quality of their life and such. And then we do an examination. Of course, in the examination, there are also basics we have to stick by. We measure the blood pressure when they're in a supine position. And then we make them stand up and we wait for 1 to 2 minutes to catch the delayed hypotension. And there are obviously other maneuvers that we can do. A golden standard maneuver, especially for BPPV, is basically Dick's Halbpike test. So how it works is that you turn the head of the patient 45 degrees, and then you quickly lay them down backwards, and their head hangs slightly off the table. This is a picture for the maneuvers. And what you're looking for is that you want to see if those, as we said, those loose crystals in the inner ear, you want to move them. You kind of want to make it happen. So if the patient gets dizzy and their eyes start to twitch, that is basically It confirms the BPPV. Next, you have a head thrust test. It kind of checks the reflex. So it checks like your balance reflex, the vestibulo-ocular reflex, if it's working properly. How we do it is that we ask the patient to keep their eyes locked on your nose, and then you quickly jerk their head slightly to the side. Normally, their eyes would stay glued to your nose, but abnormally, their eyes would move with their heads, and it will take them a second to come back and jump back to your nose. Then we have the third one, which is the side lying test. So elderlies have a lot of problems with their neck, with their back. Sometimes they cannot move their neck as much as we want to move it, for example, in the Dix Hall bike. So we just do the side lying test, and it's perfect for adults with the neck stiffness, if they have cervical arthritis, for example, or back pain. And last but not least, obviously, we watch them walk. We see their gait to see if they have any problem with the balance. So all of these, as you can tell, are intentional. And there is a meaning behind every single test that we do. And then you also have the labs. If it's something chronic, we check for the hematocrit, glucose, vitamin B12, electrolytes, and then you do an audiometry. So you want to check for cochlear symptoms. You want to differentiate between acoustic neuroma or Meniere's disease. And obviously, if you are doubting something cardiovascular like arrhythmia and such, we could go for ECG, Holter, and event monitor, tilt table testing, and neuroimaging and such. So our approach is multifactorial, be it in the history or in your labs or in our examination. And because of that, we would be able to derive to the actual diagnosis. And because of that, we're able to have a specific treatment. So for example, for vertigo, if we are having benign paroxysmal positional vertigo, we usually do Epley's maneuver, which is basically the one that we just described. It kind of puts back the calcium crystals back in place. Meniere's disease, after we have recognized it, we could do salt restrictions, we could do diuretics, acute vestibular suppressants, and if it's severe, sometimes they opt for surgery. If we're taking any autotoxic meds, we discontinue them or we substitute them or we reduce the dose. We watch the patient and how they take their medications. As I said, elderly people really don't pay attention to their antihypertensive drugs, which is a huge problem. If we're talking about presyncope, which I said is a problem with the blood flow, it depends. If there's ischemia, if there's anything, you treat it accordingly. For example, postprandial. Usually after they eat, they feel dizzy. So what we do is that we tell them, eat small meals frequently, don't exert yourself after the meal, and stand up slowly, don't stand up fast, and avoid any antihypertension drugs near mealtime. If the cause is disequilibrium, like for example, vertebrobasilar ischemia, we're going to take a low dose of aspirin, clopidogrel, or extended release aspirin. So we want to treat the cause. If they have Parkinson's, obviously we treat that, drug therapy and rehabilitation therapy. And last but not least, if it's others, and as I said, when it comes to others, we kind of think of psychiatric disorders. So we just simply give them psychotherapy or antidepressant therapy. So after having explained all that, I will show you 3 cases wherein we'll be able to recognize the cause and then afterwards see what is the appropriate approach. So you have a 72-year-old man. He comes to the emergency department because he had a sudden onset of vertigo, nausea, blurry vision, and left facial numbness while watching TV. So immediately here, I'm thinking that it's not just the dizziness, he also has focal deficit. So it's not just peripheral, it's central. The symptoms lasted a few minutes before resolving completely, which means that it's something transient. He had 2 similar episodes over the previous 3 days. He has hypertension, hyperlipidemia. He has all of the risk factors for a particular thing. And obviously his blood pressure is high, his systolic, and his heart rate is 78, which is fine. Neurological and all other findings are normal. The CT of the head is normal. So I would like to ask you guys if you can recognize what this case is. So before we answer the question, what do you think this is? If anyone can answer.
TIA, transient ischemic attack.
Exactly. Yeah. Can you tell me why you thought of TIA?
As you said, it is a central cause because dizziness plus numbness. So in the left side of the face. So it is something in the brain. Secondly, it is repeated and transient. Added on, it is old age and hypertensive look like. So this is a risk factor also for stroke.
Exactly. Perfect. Thank you so much. This is why it's important to know the types of dizziness, what causes them, and how can we treat them. Because of that multifactorial system, we were able to derive that. So hopefully we'll be able to answer this question. What would most likely establish the diagnosis for this patient? Could it be the Dix-Hallpike test or the other choices? Can anyone tell me?
Yeah, I think we in transient CT brain imaging will no effect. So we need to see the carotid arteries, Doppler ultrasound to see if there is source for emboli, like showers from atherosclerosis.
Okay, we could think of it that way, but
Also CT angio on the head and neck.
yeah, there we go. Exactly. So we basically want to see. We also want to, when we do MRI, we kind of want to rule out ischemia and such. But exactly because we have facial numbness and blurry vision, we're gonna think of TIA, obviously until proven otherwise. So the next case that we have is he's 75-year-old. He went to the emergency department. He has an episode in which he lost his consciousness. He recalls standing 45 minutes after dinner and suddenly feeling dizzy or lightheaded with generalized weakness. Before we even continue, this particular sentence I feel like would immediately light a light bulb in your brain. He remembers being on the floor, incontinent of urine. 3 minutes have passed and he immediately laid down and called 911. So he does not recall any focal neurological symptoms, and history obviously shows that he has some risk factors. So what do we think this particular case is? If anyone knows.
Is it vasovagal syncope?
Vasovagal syncope. Can you tell me why?
So you said that he was standing for 45 minutes and he's older, that he didn't have any focal neurological symptoms.
Okay, sure. But don't you think vasovagal syncope would need a particular trigger? Like it could be any stimulus that would trigger it to happen. Here we didn't really have any trigger. And there's a very important information.
I think incontinence, no explanation if it's vasovagal.
Vasovagal syncope,
How
yeah.
to explain incontinence of urine?
Come again, sorry?
If we think about vasovagal syncope, how to explain incontinence of urine?
Can anyone answer that question?
No, I kind of agree with what she said about how the incontinence probably would not explain vasovagal. So yeah, I would rethink my answer.
Yeah, exactly. So, I mean, incontinence is, it happens during syncope, but it's not really exclusive to vasovagal episodes. So really, the first thing I would personally think of is that he ate after 45 minutes, he felt dizzy. So it's most likely postprandial hypotension.
Yes.
Would you agree?
Yeah.
Okay, perfect. So we're gonna think of that. let's think of the third case, which is our last case for today. An 83-year-old woman comes to the office because she has had episodes of dizziness in the past month. Her husband died 1 year ago. She has continual unsteadiness that is unchanged by position. Very important negative points here that they mentioned. There's no new numbness or weakness. She has not fallen, but the unsteadiness has caused her to turn away from invitations and stop going to her weekly bridge game. So basically, her social life is kind of dying a little. She has not been sleeping well. She has history of hypertension, osteoarthritis, and glaucoma. What do you think is the case here?
Maybe
Persistent postural dizziness.
Come again?
Persistent postural perceptual dizziness, I think.
Why would you think that?
Because this is elderly patients with chronic non-positional dizziness without focal deficit. Is the most consistent is chronic subjective dizziness, or you can say multifactorial gaze instability rather than vertigo or cerebrovascular disease.
Okay, that's one way to think about it. But we want to look at the bigger picture here. Like we want to zoom out a little and just the first thing that comes to your mind when you read the case. Her husband died 1 year ago. She doesn't really have any numbness or weakness. And she's kind of telling you something that you don't really, as we said, if it doesn't fit the first three, then we think of the fourth thing, which is like other causes for dizziness. So, and she has not been sleeping well as well. And let's look at the examination. Maybe that would help you. She appears thin, but in no distress. She lost weight. She has normal orthostatic vital signs. She doesn't have any problem with her vision or hearing. She's strong. She has good sensory, the sensory examination is normal. And yes, her gait is slow and hesitant, but narrow-based and steady. Even though she said she has continual unsteadiness until that is unchanged by position. So would that help you come up with another diagnosis? Since everything is fine, but she just feels unsteady and her husband passed away, the first thing we would think of would probably be depression. Come again? Yes, please.
It should be a psychological cause, since everything
Ex-
organic is normal. So
Exactly. Perfect. So usually depression is like that. You have vegetative signs like weight loss, insomnia, and such. So there are major diagnoses for chronic dizziness. So yeah, we're going to answer this question. Which of the following is the best next step? I mean, since we already know the diagnosis, what are we going to choose?
Would we just screen her for depression?
Exactly. We would screen her for depression. There we go. She doesn't have any issues other than the fact that we would screen her for depression. Absolutely. And a quick recap. I hope this proved to you that it's important to know how to classify the reasons for the dizziness, to check on their meds, do their history, do the examination. In order for you to be able to answer these cases, you need to familiarize yourself. And that's eventually how you would treat your patient. I hope this was a clear presentation. If anyone has any questions, please go ahead.
Thank you very much, Dr. Almar, for that clear and insightful presentation. You highlighted an important and often challenging clinical issue, especially in older adults. And I would like to open the floor for any questions, comments, or reflection. If anyone would like to share a thought or ask a question, please feel free to do so.
Thank you so much for great presentation. This is excellent and it's an important topic. Yes, if you don't mind, I want to share with you just a video where it shows the every maneuver. I think that's it. So basically, you want to move the crystals or the stuff inside the tube there, which causes dizziness basically when they move certain ways. So to do that, you want to sit the patient and then ask them to lay on their back, of their head, turn around, and this is the steps. Thank you. So you ask them to lay down, turn the head to one side, 30 degrees, and then you can notice if there is any eye movement there. And then turn to the other side, but this time more to like 90 degrees or so. And you may need to stand beside the patient so they don't fall, and then you ask them to sit up. So again, this is just to demonstrate how the crystals will move around, and you want to reposition that or get it back to the right position. This will return to the normal, and hopefully you will have the patient will have no symptoms. And sometimes you may repeat the maneuver again in a few days or weeks. But thank you so much for great presentation. If there is no more questions, we can move on to the next topic. Thank you.
Thank you so much, Dr. Nader.
Thank you, Dr. Nader, for that insightful addition.
Appreciate it. Thank you for great presentation.
So if there are no additional points, we'll proceed to the next. Next topic, which I'll be presenting. Let me share my screen. Is it clear?
Yes, it's clear.
Yes.
Every clinician in this room knows this moment. A patient arrives, imaging appearing on the screen, a single blocked vessel suddenly tears, everything urgent. Before I go any further, I want to thank Dr. Nader for creating opportunities like this, opportunities that do not just keep us informed, but truly updated in medicine. Staying updated is not about collecting information, it's about continuously sharpening how we think, how we decide, and how we care for our patients. Spaces like this matter because they challenge routine and push us beyond what is familiar. And I chose this topic very intentionally, not because blood clots are unfamiliar to us, but because they are deeply familiar. We see them in stroke calls, in embolic disease, in acute ischemia. Every time our instinct is immediate, restore flow, save tissue, act fast. We enter these cases with purpose and confidence. We know the guidance, we know the steps, we know that minutes matter. But let me ask you this. How often do these cases go exactly as planned? Very quickly, reality sets in. Clot management is not always straightforward. Some clots respond immediately, others resist. Some procedures feel controlled and efficient, while others expose the limits of our tools, our techniques, and sometimes our expectation. We find ourselves working against anatomy, clot compositions, and technical constraints, all while time is passing. And in the brain, time is unforgiving. Neurons do not wait, they do not recover, they are lost. We often say time is pain, but clinically, time is much more personal than that. Time is speech, time is movement, time is independence, time is whether a patient returns to their life or leaves it permanently changed. Yes, current thrombectomy techniques have transformed care and saved countless lives, and as clinicians, we respect that progress. But we also recognize the limitations. Complete clot clearance is not always achieved. Outcomes are not always predictable. And sometimes, despite doing everything right, control is still feel limited. That that gap between what we aim to achieve and what our current techniques allow us to do is exactly what drew me to this topic. Because innovation does not start with technology or devices, it starts with clinical frustration. It starts with asking whether there is a more precise, more controlled, and more predictable way to interact with clots. And before we talk about new devices or mechanisms, we need to ground ourselves in the problem that makes innovation necessary. Why blood clots remains one of the most time critical emergencies we face as clinicians. Let me start with a sense I'm sure many of us here have lived through. It's early morning in ER. A previously healthy patient walks in, talking, oriented, stable vital signs. Nothing looks alarming at first glance. Then suddenly, words stop coming out right. One side of the body feels heavy. The monitor is still looks calm, but the brain is already in crisis. CT is ordered, CTA follows, and there is a clot. At that exact moment, nothing dramatic happens in the room, but biologically, everything is happening. Neurons are starving, synapses are failing, and the clock is already ticking whether we are ready for not or not. How many times have we watched the scan load and felt that pressure because we know the tissue is not waiting? And that is the uncomfortable truth we face as clinicians. But the time we see the clot, the damage has already started. So why do blood clots escalate so quickly from a finding on a scan to a full medical emergency? The answer lies is what happens the moment a clot forms. It starts with vascular flow obstruction. A clot does not just sit in the vessels, it occupies the lumen. It disrupts laminar flow, reduces perfusion, or it stops it entirely. And once blood flow is compromised, the tissue downstream immediately enters a danger zone because blood flow is not optional. It is a delivery system for oxygen, glucose, and cellular survival. Once flow is obstructed, the next step is inevitable: acute tissue ischemia. This is not a static condition. Ischemia is an active injury process. Cells shift from aerobic metabolism to failure pathways. ATP levels fall, ion pumps fail, edema develops, acidosis worsens, and minute by minute tissue moves from potentially salvageable to irreversibly damaged. When this process involves the brain, the stocks rise even higher. This is where ischemic stroke risk comes in. Neurons have extremely high metabolic demand and almost no tolerance for oxygen deprivation. Even short interruption in perfusion can translate into permanent loss of function. That is why we see rapid neurological injury, not hours later, not the next day, but often within minutes. Loss of speech, loss of movement, altered consciousness, consciousness. And while we are assessing imaging and coordinating care, the tissue does not pause. The injury continues, which brings us to the most critical concept on this slide, time critical intervention. In clot-related emergencies, time is not just a factor. Time is the outcome determinant. Every minute of resistant occlusions expands irreversible injury and shrinks the window for recovery. Early perfusion saves tissue. Delayed perfusion locks in disability. This is why clots are not just radiological findings. They are biological countdowns, and they demand immediate, precise intervention. So if the disease process is this fast and this unforgiving, then our treatment strategies must be able to match the urgency. And that brings us to the next question. Are our current clot removal techniques truly designed to be this clot every time? So what we actually do right now in real clinical practice, we essentially have three major lines: suction, mechanical devices, and endovascular catheter approaches. Let's walk through them quickly but clinically. First, suction-based thrombectomy. Think of it as the most direct concept. Engage the clot and aspirate, remove the obstruction and restore flow. Clinically, what makes aspiration appealing is simplicity. You are not trying to dance around the clot. You are trying to own it, capture it at the face, and pull it out. And when it works, it can feel almost immediate. Flow improves, distal perfusion returns, physiology settles. It's the closest thing to remove the problem right now. But remember, this is a physical object in a dynamic vessel. So the key is engagement. Mechanical clot removal devices. The second, mechanical clot removal devices. This is where field moves from suction alone to intentional clot device interaction. These devices are designed to grip, trap, or mobilize the clot, then extract it, often in a controlled way. Clinically, this approach is powerful because it acknowledges reality. Clots are not all the same. Some are firm, some are layered, some are anchored. So mechanical devices came to answer one central clinical need. If aspiration does not fully capture it, how do we physically secure it? And that is why across modern stroke and vascular intervention, mechanical strategies became a core part of a toolbox. Third, endovascular catheter approaches. This is a navigation lane, the ability to reach the target safely and precisely. Because before we remove anything, we have to get there through thoracic anatomy, tight turns, delicate vessel tool, and time breather. Endovascular approaches do not just support clot remover, they enable it. They are infrastructure, catheters, guide wires, microcatheters, everything that make the intervention possible. This is where clinical skills meet anatomy and where minutes matters. So if we step back, our current world is built on aspiration tool, mechanical tools to secure, and endovascular navigation to reach. And honestly, this toolbox has already changed outcomes. But there is the key clinical question: do these approaches deliver the same success in every clot, in every vessel, in every patient? That is exactly why this slide is matters. Because in real life, that we struggle with is not having tools. In real life, we struggle with is not having tools. We struggle with is consistency, predictability, and time. So let's talk about where current clot removal techniques is still fall short. So we have named the limitations: clearly time pressure, unpredictable success, and the consistent fear of vessel injury. Sorry. So let us discuss the limitation of the current clot removal techniques. Firstly, time-dependent outcomes. Can you hear me?
Yes, we can.
Hello.
Yes, we can. Your voice is coming clear, yes.
Okay, so let's move into the limitation of the current clot removal techniques. So firstly, we have a time-dependent outcomes, and we have the incomplete clot clearance, and we have the high technical complexity.
Is the voice cutting or it's only for me? Is it on and off?
Yes, it's cutting a little bit.
Yes, I guess it's gotten. Dr. Malaz, we can't
No,
hear
it's
you right now.
completely done. I'm not sure if she can hear us, but I can see her mouse moving, but no sound is reaching.
Maybe it's a microphone issue.
Probably could be.
Dr. Malaz?
Hello. I don't know why, actually. Can you hear me well?
Yes,
Yes,
now
now
we
we
can,
can.
but we couldn't hear you like for a couple of minutes ago.
Yeah.
Wait, let me actually check my connection. Sorry for my bad internet connection. I'm sorry. Let me to share screen again. Is it clear?
Yes, the screen is clear, but
My voice, yeah.
yes.
I don't know why. Okay.
But currently we can hear you pretty well, I guess.
Okay, I'm gonna
I
move
hope I'm not
it
the only one.
quickly. Okay.
Yes, we
So-
can clearly hear you, Dr. Malaz.
Okay. So regarding the limitation of the current clot removal techniques, So, firstly, time-dependent outcomes. So, in clot-related emergencies, time is not a variable. It's a predict. Every minute of delay means more tissue loss and worse outcomes. Current techniques work only if we arrive early enough, and all of us know that. Second, variable efficacy. Even when we act on time, results are unpredictable. Some clots respond, others resist. Outcomes vary from patient to patient, vessels to vessels, as you know. Third, incomplete clot clearance. Partial removal is not success. Residual clot fragments can continue to obstruct flow, increase recurrence risk, and compromise recovery. Fourth, prolonged procedures. Longer procedures means longer ischemia, more complication, and higher strain on both patients and clinical team. Fifth, high technical complexity. Many current methods demand advanced skills, steep learning curves, and specialized setups limiting scalability and rapid employment. And when we put all these together, one conclusion becomes clear. There is an urgent need for faster, more predictable, and more efficient clot removal solution. So now we have named the limitations clearly: time pressure, unpredictable success, and the constant fear of vessel injury. This is a moment where the innovation truly earns its place. Because instead of asking how do we pull the clot out faster, this technology asks a more powerful question: what if we change the clot itself right where it's sitting until it becomes easier, safer, and faster to clear? That is a core philosophy behind the mini spinner. So, mini spinner is miniaturized catheter tip spinning device. Let's start with design because the brilliance here is where the solutions live. This is not a bulky machine outside the body. It's not complicated external system that changes the whole procedure. It's a tiny spinning component sitting at the very end of long catheter, meaning it can reach the clot in narrow, delicate vessels. And clinically, that matters because when the clot is deep, distal, or in a sensitive territory, the approach itself can be the biggest limitations. So the first step in the innovation is simple but bold: deliver the mechanisms directly to obstructions without increasing invasiveness. Two, targeted mechanical clot fragmentation. Now here is the turning point in the story. The initial instinct was suction because that is what we were trained to trust. Grab it, aspirate it, remove it. But suction alone was not breakthrough. When rotation When rotation enters the picture, something unexpectedly elegant happened. The cloth did not just break, it started to change behavior. Think of a soft, boiled piece, something that when you roll it gently again and again, it does not explode, right? It reshapes. The cloth becomes smoother, more compact, and progressively easier to reduce. So instead of brute force extraction, we are doing something more controlled. We are mechanically conditioning the clot. And that is why the term disruption is actually accurate. It's not a violent tear. It's a progressive transformation. Third, controlled, precision-driven intravascular action. And this is where the clinician in all of us should join in, because the danger in clot intervention is rarely a clot alone. It's the vessels, right? The mini spinner's strength is that the energy is focused at the clot interface. It's localized, it's controlled, it's repeatable, which means your goal becomes minimize uncontrolled traction, minimize prolonged instrumentation, and avoid unnecessary vessel wall trauma. In other words, you are not fighting the vessels to win against the clot. You are shaping the clot while respecting the vessels. First, designing to overcome current thrombectomy limitations. Now connect this to what we have already seen. If outcomes are time dependent, this aims to shorten the struggle by making the clot easier to deal with sooner. If efficacy is variable, this aims for a more predictable mechanical interaction. If procedures become prolonged, this aims to reduce time by transforming the target instead of escalating force. And if safety is the concern, especially in cerebral circulation, then a controlled action at the clot makes perfect clinical sense. And that is why this is not just another device. This is a strategy shift from extracting a stubborn obstruction to modifying a biological structure until it becomes removable with less risk. So the main spinner does not win by pulling harder, it wins by being smarter about what a clot actually is mechanically. So how does it work inside the vessels? Step by step from navigation to activation to flow restoration. So up to this point, we have talked about why we need different approaches to clot removal. We saw the limitations and understand the risks. So now let's zoom in literally inside the vessels and walk through what actually happens once this device is deployed. Catheter navigation, firstly. Everything is started in a very familiar way. The catheter is navigated through the vasculature under imaging guidance. Just like any endovascular interventions we perform today, there is nothing dramatic here, and that is intentional because innovation that fits into existing clinical workflows is far more likely to translate into real practice. And at this stage, the vessels is still occluded, the tissue is still ischemic, and the clot is still ticking. Then a spinner activation. And this is where the shift happens here. Once the catheter tip reaches the clot, the mini spinner is activated. And instead of pulling the clot, and instead of aspirating aggressively, the device introduces controlled rotational motion directly at the site of obstruction. This is not force for the sake of force. This is precision. Clot disruption. As the spinner rotates, the clot begins to change its behavior rather than tearing unpredictably or resisting extraction. The clot undergoes gradual mechanical fragmentation. It becomes smoother, more compact, less anchored to the vessel wall. One way to think about this, the clot is no longer fighting the intervention, it's adapting to it. Okay, and that is crucial difference, vessel preservation, because the energy is focused on the clot itself. The vessel wall experiences significantly less trauma. There is less shear stress, less prolonged contact, and less risk of endothelial injury. From a clinical standpoint, this matters enormously because a vessel preservation today means fewer complications tomorrow. Flow restoration. And finally, as the clot burden decreases, blood flow begins to return, not suddenly, not violently, but progressively and predictably. Perfusion is restored, ischemia is interrupted, and the vessels remain structurally intact. This is not a clot removal, this is a physiological recovery. So after seeing how the mini spinners actually work inside the vessels, the real question becomes, why does this approach matter clinically? Why does it feel different when we imagine using it on a real patient? Let's walk through that step by step. Why the mini spinners stand out? It starts with precision, because the first thing we notice is that this device does not act from a distance. It does not pull blindly or apply force across the entire vessels. Instead, the disruptions happens exactly at the side of the clot. And once you localize the action, you immediately change the nature of the procedures. The precision naturally demands control. When you work at the clot itself, you do not need aggressive force, you need controlled motion. This is where rotational mechanisms becomes critical. The clot is not turned or dragged. It's gradually reshaped, softened, and broken down in a predictable way. And as clinicians, we know control is what separates a technically successful procedure from a same one. And when control improves, time follows. Because when the interaction is predictable, you do not need repeated passes. You do not escalate force. You do not keep adjusting strategy mid-procedure. The process becomes more efficient, and in acute ischemia, every minute we save in neuronal tissue we protect. But speed alone is not enough. The real challenge is whether that efficiency holds across different clot types. We have all experienced it. One clot comes out easily, another resists everything. What's compelling here is that this mechanism does not rely on suction or clot softness. It relies on mechanical interaction, which means the performance becomes more consistent regardless of clot composition. And consistency brings us to safety. Because when you are not fighting the clot, you are also not fighting the vessels. Less traction, less wall stress, less unintended endothelial injury. The device is designed to preserve the vessels while resolving the obstruction. And vessel preservation is not a luxury. It's a requirement, especially in cerebral circulation. When we put all that together, the outcome becomes real. Targeted actions leads to control. Control leads to efficiency. Efficiency leads to consistency. And consistency allows vessel protection. And all of that supports what we ultimately care about. Rapid, safe perfusion, not just opening an artery, but restoring flow in a way that gives the brain a real chance to recover. So this is not just a new device, it's a different of clot removal. The next question then is obvious. Where does this technically stand today, and how close we are to seeing it move from the lab to bedside? So we need to pause briefly and ask the most important clinical question. Where exactly does this device stand today? Not where we hope it will be, but where the evidence actually puts it. First, proof of concept. This is not an idea that lies only on paper. The mechanisms was first established in controlled laboratory settings where the goal wasn't speed or clinical outcomes, but understanding behavior. How does the clot respond to rotation? Does it fragment it in a predictable way? And most importantly, does the vessels tolerate that interaction? That foundational step matters because without it, nothing else is safe to build on. From there, the questions became more realistic. Laboratory success means very little if it does not hold once flow is introduced. So the device was tested in stimulated vascular flow models, systems designed to replicate real intravascular conditions, continuous flow pressure gradients, and resistance. This step answers a key clinical concern. Will the mechanism still behave the same once blood is actually moving? And the results showed the clot device interaction remained effective even under dynamic flow conditions. But vessels are not plastic tubes. So the evaluations moved closer to biological reality. So in ex vivo testing, the device interacted with real vascular tissue and real clot material. Here, what stood out was not just the clot could be disrupted, but that interaction was controlled. There was effective engagement with the clot without aggressive trauma to the vessel wall. And for anyone who has worried about endothelial injury, dissection, or downstream immobilization, this is a critical observation. Equally important was consistency. This was not one-off success. Across repeated testing, the mechanical performance was reproducible and reliable. Same setup, same activation, same response, and consistency is what separates a clever idea from something that could realistically enter clinical workflows. Um, Now comes to the honest boundary of the evidence. As of today, no human clinical trials have been conducted, and that is not a failure. That is reasonable development. It tells us um, that while the mechanical and preclinical data are promising, the device has not yet earned its place at the bedside. Okay, which brings us to the final point and the most important one. Further safety evaluation is still required. Regulatory approval is still needed, and carefully designed human studies must come next. Because in medicine, innovation does not move forward by excitement alone. It moves forward by evidence, safety, and trust. So what we are seeing here is not a finished clinical tool, but a technology that has passed the early gates responsibly and is now standing at the threshold of translation. So the real question is no longer does this work, but how do we bring it safely into patient care? But as clinicians, innovation only matters when it answers one question: what changes for my patient tomorrow? If this reaches the bedside, that is where the future of this technology becomes truly exciting. Future directions and clinical potential deep connected explanation. First, devices optimization for clinical use. The next phase is not about inventing something new. It's about refining something that already shows promise. Device optimization here means making sure the mini spinner behaves reliably inside real human vessels with all their curves, branches, and fragility. It's about precision control, predictable response, and performance that does not depend on perfect conditions. Because in real life, vessels are never perfect, and neither are clots. Integrations into endovascular workflows. And this is critical. No matter how advanced advice is, if it disrupts workflows, it will not survive in clinical practice. The strength of this approach is that it's designed to fit into existing endovascular procedures, not replace them. Same access routes, same imaging guidance, minimal adjustment for the other operator. It becomes an extension of what interventionists already do, not an obstacle. Third, reduce procedure time and complexity. Now this is where the clinical impact becomes tangible. Current thrombectomy can be effective, but often at the cost of multiple passes, prolonged manipulation, and raising procedure risk by altering how the clot behaves rather than fighting it. This approach has the potential to shorten procedures significantly, fewer steps, less resistance, more efficient reperfusion, and in stroke care, time saved is pain saved. That is not a slogan, it's biology. More consistent clot removal, one of the most frustrating realities in practice, is how unpredictable clots can be. Same patient profile, same results, different outcome just because the clot behaves differently. This technology aims to reduce the variability by mechanically modifying clot structure in a controlled way. The goal is consistency across clot types, soft or firm, fresh or organized. Consistency is what turns a promising idea into a dependable clinical tool. Pathway toward first in human trials. And finally, the state that truly defines the future. All of this work points toward a careful structured transitions into first in human studies. not risk, not experimental for the sake of novelty, but guided by safety, reproducibility, and a clear understanding of risk. Because meaningful innovation in medicine does not lead to bedside; it earns its way here. Its way there. Powerful closing when we talk about the future of the mini spinner, we're not just talking about a new device, we're talking about possibility of faster decisions, more predictable outcomes, and safer clot removal when every second truly matters. So let me end with this. Every one of us in his room has faced that moment. The scan is loading, the clock is running, and we already know the truth. The tissue is not waiting. Blood clots does not announce themselves politely. They do not give us time to prepare. They do not respect our protocol or our workflows. They arrive fast, silent, and unforgiving. And for years, our response has been fight them harder, a stronger section, more force, more manipulation, while accepting the same trade-offs, time loss, variability, and risk to the vessels we are trying to save. What we have explored today represents a shift, not in technology alone, but in thinking, a shift from pulling to transforming, from reacting to obstruction to controlling its behavior. This approach asks a different question. What if clot removal did not depend on force, but on precision? What if consistency replaced unpredictability? What if speed came from control, not aggression? Because when reperfusion is achieved early, the story changes. A deficit becomes reversible, a stroke becomes um, solvable, a life returns to itself. And that is why this matters, not because the device is small, not because the engineering is elegant, but because one day this kind of innovation may be the reason a patient walks out of the hospital instead of learning how to live with loss from bench to bedside. Um, Precision-driven clot disruption is more than a technical advancement. It's a statement that we refuse to accept delay as inevitable, that we refuse to accept inconsistency as normal, and that we believe the future of vascular intervention should be faster, safer, and intentional because in the end, innovation is not about devices. It's about time regained, function preserved, and lives that still have a chance. So thank you so much. If there is any questions, reflections, or clinical perspectives you would like to share, I would be happy to discuss them.
Thank you so much, Dr. Malaz, for this also great presentation. Any questions? If not, we can move on to the next topic. Thank you.
Actually, I have one tiny question. I don't know if I didn't get the suction-based thrombectomy right, or I mean, like, when in the suction-based thrombectomy, can this method cause the migration of like debris, smaller clots, when we try to like remove the clot from its place? Isn't it like kind of dangerous, or?
So my understanding, and Malaz, please correct me if I'm wrong, that when they use these devices, they will have a net behind the device. So usually if the direction of the flow this way, you attack the clot, and then you use the suction. And as you said, maybe there are some debris or small fragments. So usually there is a net where they can be captured. I think so. But Malaz, do you have any comments? Thank you.
Thank you, Dr. Nader. Actually, I didn't share well. Actually, my internet connection today was so bad. I'm sorry.
That's okay, but we can figure it out, or we can find out if there is other ways to prevent complication. But thank you so much for the question.
Thank you. I think the net makes sense if I can imagine it. Probably for the bigger clots, because the tiny little ones could get eliminated, but like the bigger one who can cause problems in other vessels that can cause problem. But I didn't know there was a net, so thank you.
No worries. And I think the idea is the same when you have a DVT in the legs. They put the IVC clot catcher there, or a filter where if the clot travels, then it will not end up at the lung.
Close to the heart.
Yeah.
Lungs.
Thank you.
Thank you. Thank you so much.
Appreciate it. Yeah. We can move to the next topic. If you are ready, please, presenter can start.
Dr. Ayah, abdalla, if you're ready.
Yeah. Hello, everybody. It's really pleasure to meet you today. I'll be talking about tips and tricks for building a good scientific paper from the editor's point of view. I'm just going to share my screen now with you guys. Okay, so yeah, can you see the screen now?
Yes.
Okay, perfect. So generally, we know that there's a lot of pressure to publish more papers these days. The thing is that sometimes these studies may fail to get accepted, not because of poor science or poor data inside these papers, but because of the poor work or the poor way that these work was presented. Okay, so this is what we're going to talk about briefly today. So generally, from the editor's point of view, okay, they are responsible for maintaining the scientific quality and credibility for their journals. And their goal is not just to publish data, but to publish work that is clear, relevant, and methodologically sound. Okay? This is why even good studies, okay, they get rejected if they are poorly presented. Okay? So today we will focus on understanding the editorial perspective and highlight the key elements that influence acceptance or rejection of the manuscript. Okay, so first of all, before we move further, I would like to ask you a question. From your point of view, what do you think is the most important part of the paper that the editors usually focus on that really affects the acceptance of that paper? Which part of the paper do you think most influence an editor's first decision? So if we said that the paper is title, abstract, introduction, and then methodology, results, discussion, which part do you think is the most important that catches the editor's attention first and has most implication on the decision?
Let's say the
Maybe
abstract.
abstract.
Yeah, I also think it might be the abstract.
I think it's the
Okay.
methodology.
Okay, good. So I would say, so we will definitely answer this question throughout this presentation today. Okay. But to start with, I would say title and abstract are the most important and most catchy and for determining the acceptance for that paper, but the methodology is also crucial. Okay. So what about the editor's perspective? Editors screen manuscripts before peer review, and the decision often made within minutes during initial assessment. Okay, so as we said, they are looking for clarity, relevance, novelty, and methodological soundness. A well-written paper reflects a well-conducted study. Okay, so let's start with the title. The title gives the first impression, and the first impression always matters. The title is the first and most important element editors read. It should be concise and clear, informative. Prefer one line. They always prefer one line. You can add a second line if you need to, but always try to make it as concise and clear as possible. Avoid unnecessary words and jargon. State the main findings rather than asking a question. Okay, so how to make a strong title? Okay, let's just try to make it short and specific as much as we can, accurately reflects the study content, scientifically correct and serious in tone, okay, and attractive without being sensationalized. Okay, so this was about the title. What about the abstract? Okay, the abstract often determines whether the editor continues reading or not. Must state clearly the background, the purpose, the methods and results and conclusion. Avoid vague statements and unsupported claims. This is the most these are one of the most common mistakes that people do, is that they put unsupported claims in their abstracts. So let's try to avoid doing that and ensure it's concise with the consistent with the main text. Okay, so let's look into the introduction. Okay, introduction briefly explains what is known and what is unknown and clearly identify the research gap. Explain why the study is necessary and relevant, and end with a clear focus study aim or hypothesis. This is how to make our introduction really strong. Okay, what about introduction mistakes? There are so common mistakes in the introduction. Some people make it too long, okay, an unfocused background, lack of clear research question, and overstating the importance of the study. I mean, we need to state the importance, but not overstating. And also sometimes people include results or conclusions prematurely. No results or conclusions should be included in the introduction. Okay. When it comes to the methods, scientific credibility. So editors carefully assess the methodology section. Study design must match the research question. Okay, and the method should be detailed enough for reproducibility, ethical approval, and this is really, really important. Okay, they always ask about it. Ethical approval and statistic must be clearly stated in the methodology section. Okay. When it comes to the results, clear and logical presentation of results. Let's try to present our results in a logical sequence. Avoid interpretation in results section. Okay, we are not going to interpret in the results section. That is going to happen in the discussion section. Use tables and figures effectively without duplication and ensure statistical results are clearly reported. Okay, so in the discussion, Okay, what we're going to do is to interpret the findings. We start with a brief summary of key findings and explain how results compare with the existing literature, discuss clinical or scientific relevance, and avoid over-interpretation or unsupported conclusion. Okay. And then finally, after we discuss our finding and interpret our results, we're going to acknowledge the limitations of our study, and we need to be very honest in this section because editors really appreciate transparency and honesty. Discuss limitations that may affect interpretation, explain how limitations were minimized when possible, and avoid defensive or dismissive language. Just try to be as honest as possible, okay? And finally, the conclusion. The conclusion has to be clear and balanced, okay? Directly answers the research question, keep conclusions consistent with the results, and avoid introducing new data or claims. No new data in the conclusion section, okay? Highlight practical or future implication would also be helpful, and increase the possibility for your paper to get accepted in that journal. So, general speaking, the language and the style and clarity generally in all sections, let's try to be clear, simple language, make it scientific language, avoid unnecessary jargon. Good English reflects professionalism. So it's just try to be, not very sophisticated or difficult, complicated style or language. Just try to make it as accurate and correct as possible. Avoid spelling mistakes, avoid grammatical mistakes. Consider professional language editing if needed. Okay. In the figures and table in results section, okay, it must be self-explanatory and well labeled. Avoid overcrowding with excessive data. Figures should complement, not repeat the text. And this is really important because some people sometimes tend to repeat the result, repeat the text in a form of figures. Okay, it should be complementary, and then high quality visual improve editor perception to your paper. Okay. Then in the reference and publication ethics, cite and literature, avoid excessive self-citation, disclose any conflict of interest, and ensure originality and avoid plagiarism. These are really basics of scientific writing when it comes to writing your paper. Avoid plagiarism. So what are the common reasons when editors reject your paper? It could be out of journal scope. It could be poor study design or weak methodology, lack of novelty or relevance, and poor writing or unclear presentation. So let's just try to choose the right journal for the right title or for the right study, and then try to make the methodology section as strong as possible. Okay, and then when it comes to writing, let's make it very clear writing, clear presentation of our data. So finally, before submitting our list, what should we do? Does the title clearly reflect the study? Is the abstract accurate and complete? Are methods and statistics sound? Is the manuscript clear, concise, and well structured? So before submitting our manuscript or paper, just try to double check all of these, and hopefully it would be accepted. So does anyone have any questions so far? I believe this is a really simple, straightforward topic for today. And I hope it helps you guys next time when trying to publish your papers. Thank you.
I don't know if it's a question, but maybe it's something that I could throw out there for discussion. First of all, thank you so much, Dr. Malaz and Dr. Ayah, for the amazing presentations. But recently there was kind of a change regarding the criteria as to the kind of papers they would consider or something like that. So it's kind of, they prefer now the quality more than the quantity. So they don't really care if you fill your CV with whatever you did in the paper for the research. So I feel like this is a really important topic to talk about with the tricks and everything, because now they're focusing more on quality more than quantity, I think.
Thank you so much for the great presentation, and thanks for the comment. Any questions or any other additional comments? If not, we can move on to the next topic. Thank you again.
I have a tiny question regarding the ethical approval. Like, what does lean in the methodology section? So, what do we mean by the ethical approval? Like, should it be approved by some?
Yeah. So when it comes to methodology, if you did a data collection, okay, so you need to state clearly that before starting the collection, the proposal of your research project was approved by an institutional review board, okay, and then you took ethical approval or from the patients that you made the data collection from. Okay, you should state that clearly in the methodology section.
Okay, thank you.
Thank you so much.
Thank you, Dr. Ayah, for the insightful presentation. So let us welcome Dr. Sara Ali, who will present on magnetic robot for kidney stone management. If you are ready, please go ahead.
Okay. أول شيء السلام عليكم جميعا. Thank you so much Dr. Malaz for facilitating this, and thank you Dr. Nadir for being such a great mentor to all of us. Dr. Ayah, Dr. Almar, thank you guys so much for the presentations. So I'm just gonna go ahead and share my screen. Okay. Okay, can everyone see my screen?
Yes.
Okay. All right, so today I'm going to be talking about emerging magnetic approaches in kidney stone therapy. Right. All right, so here's just a rough draft of the PowerPoint. I'll try to keep it short. It's going to be no more than 10 slides of content, inshallah. So let's start with just an overview of kidney stones. Can you guys see my screen still?
Yes, we do.
Yeah, your
Okay.
screen is.
Okay. All right. So medically, kidney stones, of course, are known as nephrolithiasis. Nephro meaning kidney, lith, of course, meaning stone, and iasis meaning disease of. So nephrolithiasis is essentially just a disease where you have stones in your kidneys. So the way that these
Dr. Sara,
stones,
sorry for interruption, but can you please make the slideshow in full screen, please? Sorry. Can you click the slideshow and make it in full screen presentation?
yeah, هسي عملناه full screen ما ظاهر لكم full.
Is it clear for you guys? Our full screen presentation?
Dr. Sarah, can you unshare the screen and then
Okay.
share and then click on the presentation rather than the document, the PowerPoint? Thank you.
Okay. Like this? Is it visible?
I don't know about everyone else, but
It's not coming.
I don't think I'm seeing anything.
You're not seeing, okay. I'm not sure what I'm doing wrong.
It's black screen.
Now it's black. Oh, okay. Magnetic kidney stones. Okay, is it clear now? Or is it
Sadly, nothing
still?
is showing. Maybe you can send it in the chat and maybe I can screen share it for you.
Okay, yeah, I'll try that. It's still not. Okay.
Well, now it's showing, but it's like
Mhm.
saying click to exit full screen.
Okay. Sorry, technology is not my strong suit.
Now kidney stones.
طيب هسي ظاهر لكم ولا؟
أيوة ظهرت.
Yeah, but the moment you pressed on slideshow, I think it lagged or something. It's not showing the slideshow you're meant to show.
So Sarah,
Okay.
now you are
I
on
think
the PowerPoint or the slides, Google Slides, slides on the left side and each slide presentation on the right side, the big one. But if you go down to the right upper corner, there is a slideshow on the right. Yeah, click on it.
slideshow.
Yes,
Okay.
it's loading.
Okay. It's showing on my screen. Is it showing on yours?
It's loading.
Or not
It
yet?
says it's loading. I know.
It's still loading.
Okay. Why don't
Maybe I can do what Dictora Almar suggested and
can you click on share next to slide share slideshow, and then you can share it with Dr. Malaz maybe or someone. Yeah.
Okay, what's the email I'm supposed to share it to? معلش دكتورة ملاز بس ممكن your email so I can share it with you also.
Yeah, okay.
Okay.
Right.
It's in the chat.
It's in the chat.
Malaz Salah 43@gmail.com.
That's 43.
Yeah, I see it. Wait, let me just open.
Oh, is it visible now?
Yes.
Now it's visible? Okay. Okay, I'm not sure what I did, but okay, I'm glad it's visible now. All right, so back to okay, can everyone hear me clearly?
Yeah.
Yes,
Okay.
you can go ahead.
All right, okay, thank you. So as you know, kidney stones are medically known as nephrolithiasis. They're essentially supersaturated crystals that form from different substances that precipitate along the urinary tract. And it can be anywhere along the urinary tract, from the ureters to the kidneys to the urethra. And of course, increased pH and concentration of those crystals also increase the likelihood of stones forming. Kidney stones have a global prevalence of about 12%. And I know 12% does not sound like a very big number, but I think with the global population being almost, I think, 8 billion now, you're talking, tens of millions of people having to experience kidney stones. So that's a relatively large number, unfortunately. So a few of the risk factors of kidney stones include lifestyle and diet. If someone's dehydrated or they have a high sodium diet, or even consuming a lot of animal protein, which can precipitate uric acid crystals, that increases their risk of developing kidney stones, as well as medical history. For family history, I believe there's a 2.5% or 2.5 times increase in someone getting kidney stones if they have a first-degree relative that has them. And of course, prior history of kidney stones also increases the risk. And obesity, as well as certain endocrine disorders such as cystinuria, hyperparathyroidism, hypercalcemia, those all can also precipitate stones. We also have in children, the pediatric population, GU malformations and cystinuria are pretty large risk factors. As far as medical medications, very high doses of vitamin C can precipitate kidney stones, as well as Indinavir, which it's an antiretroviral treatment, I believe, and triamterene also, which is used for hypertension, can also precipitate it. So the American Urological Association classification of crystals, they classify it by both type and size. As far as type, there's several different types. I just listed a few here. It's just as calcium oxalate. We usually see those in individuals with pure vegan diets. Calcium phosphate kidney stones are also one of the most common kinds. We have uric acid stones, which are usually a result of any kinds of dietary factors or lifestyle decisions that cause an increased buildup of uric acid, such as obesity, alcoholism, even family history, for example, or genetic predispositions such as Lesch-Nyhan syndrome. Those all are risk factors for uric acid stones. And then we have the magnesium ammonium phosphate stones. This one is usually an infectious cause. For example, Klebsiella and Proteus can cause these kinds of stones. And then, of course, there's cystine, which we usually see in the pediatric population, especially children who suffer from cystinuria, which is essentially a defect in the kidney tubules, which causes, I believe it's abnormal reabsorption of the different substances which can cause kidney stones, such as cystine, ornithine, and lysine. So as far as the size, this is more relevant for treatment, which I will discuss more in the next slide. And for patient presentation, usually patients present with very sudden and very severe colicky pain that may radiate to the groin. One of the signs may be hematuria as well. And a few complications, if it's untreated, would be hydronephrosis, which is dilation of the renal pelvis and calyces. And that can, of course, cause pressure atrophy of the kidneys, as well as sepsis, chronic kidney disease, and unfortunately, if untreated, it can even lead to kidney failure. So we can see that although kidney stones may seem like not a very big deal, if you will, they actually have very dire consequences if they're not treated. But luckily, there are multiple treatment options that we use, mostly according to size, as you all can see here. So current treatments, so in smaller kidney stones that are less than 5 millimeters, those usually are self-limiting, and we just use conservative treatment, such as oral fluids and basic analgesics, such as NSAIDs. They're very likely to pass on their own, so this is why usually more therapies are not usually used, just because it is self-limiting. And for stones that are between 5 to 10 millimeters, we commonly use medical explosive therapy with alpha blockers such as tamsulosin. Of course, alpha receptors in the kidneys, they contract the ureters. So if we block that effect, then we have relaxation of the ureters, and that helps with facilitating the passage of the stones. And this is especially effective for more distal kidney stones. So for the 10 to 20 millimeters, anything past 10 millimeters, we have to consult urology, just because it would require more procedural treatments. So from 10 to 20 millimeters, we have shockwave lithotripsy. This is actually non-invasive procedure that fragments stones, and I'll show you more on this slide here. On the left side, you can see that there's a simulation of the procedure in which shock waves are used to break the stones. It's non-invasive and usually is only 1 to 2 days for recovery. But the complications of it is that it's not as effective for large stones, and it may leave some fragments unbroken. So as a result, some patients may need repeat sessions of this, and some complications would be pain from the procedure as well as increased risk of infection. And then for stones that are very large, over 20 millimeters, we would use, or the urologist would use, percutaneous nephrolithotomy. And this, as you can see on your right, it's essentially a treatment that removes stones by a percutaneous renal axis. And this is also done under anesthesia. A small incision is done on the back, as you can see on the right side picture, and the urologist would go in and he would physically use the device to break the stone and remove the fragments. But complications, of course, with all surgeries, you have the complication of hemorrhage. With this specifically, the risk of kidney perforation and injury to adjacent structures is also high. So moving on to the medical limitations. So kidney stone prevalence has actually doubled over the past decade, according to Lee et al., and recurrent rates remain very high, especially in patients with prior stones and in the pediatric population, cystinuria. The extracorporeal shockwave lithotripsy and the percutaneous nephropathy are effective, but as you all heard earlier, they have risks of bleeding and infection and residual fragments. So of course, reducing patient morbidity and also maintaining efficacy remains a very major priority clinically. And so it's because of these limitations that researchers have begun exploring magnetically guided therapies as an alternative. Yeah. Because as you all can see, the challenges that we see here, they highlight the need for more targeted and less invasive approaches. And that's exactly what the researchers that I am about to discuss with you all aim to address. All right. So we have the question of whether magnetic therapy in urological disease, specifically kidney stones, could possibly be the next frontier. And there's a few studies that I read regarding this, but one of the biggest ones, which was done in 2015, was by researchers Kabazian et al. They developed very small magnetic robots that can be magnetically steered through the urinary tract to actively dissolve in this case, they use uric acid kidney stones with the use of urease, which is an enzyme that would break down the urea that is causing the kidney stones. And there's actually a model that they use to do this here. So in this model here, you all can see that they use a soft urease loaded magnetic filament here in the very bottom of the diagram. And it's guided by external magnets and ultrasound through the urinary tract to dissolve the stones locally, and then they retrieve it through a catheter, as you all can see on the bottom right side of the model. And this essentially replaces mechanical fragmentation with more targeted and localized dissolution of the stones. So the aim here is that they want to be able to provide a non-invasive and targeted treatment without surgery. And this may actually avoid the side effects and slow dissolution that we see with oral treatments. And it allows real-time steering and guidance through the ultrasound. So the findings in this model from Kabazayan is that they saw a 30% reduction in uric acid stone mass after 5 days. And the enzyme activity, the urease itself, actually preserved for over 65 days. And the robots are trackable with clinical ultrasound. So, right, here's the diagram again. Does anyone have any questions until now? Okay. All right, so
it is only for
let's now.
uric acid stones?
So in this model specifically, they only use uric acid stones. Yes.
Okay.
But we'll see more models in the next slide. So some more studies that I looked at was one study by Zhou et al. Was a systematic review showing that magnetic ureteral stents allow faster and less painful office removal compared to more conventional stents, which eliminated the need for cystoscopy in most cases. And Jay et al. Developed a magnetic hydrogel system that coats the kidney stone fragments after the lithotripsy. And this allowed surgeons to remove multiple fragments simultaneously. So they were able to remove multiple fragments at the same time using a magnetic wire. And this was in a porcine model, so it was not in a human model, but it's still promising research nonetheless. Okay, so to look at, so far we've only seen the use of magnets, theoretically or in animals, as far as kidney stones go. But what's fascinating is that these magnets can also be applied to other fields. So here, for example, in vascular surgery, I know Dr. Malaz was presenting to us about, vascular surgery techniques earlier. So this is kind of a nice tie-in to that. So Tin Nguyen and his colleagues actually pioneered steering microrobots that can carry the drugs directly to the tumors or the disease vessels. And these microrobots can be navigated through the fluid environment of the blood vessels, and the drugs can actually be released locally at target sites. So this provides more precise control. And we can see a diagram in this slide here. Yeah. So, right, this looks overwhelming, but just allow me to explain it. So essentially in this diagram, what we're seeing is the magnet, right? So like the robot that they use to guide the magnet is essentially inserted into the blood vessel, right? So you can see if you follow me from the bottom left, right? So you have the robot, the drug goes inside of the magnetic robot, and then continue moving to the right, and you can see that the X-ray contrast, the X-rays, it loads the contrast agent, and then the person doing the procedure is able to hold and release the drug. So you can see the drug traveling all the way up to the blood vessel, and then the top right, we can see the cancer region. And then that is where the drug can be triggered to be released. So that's a model that Nguyen et al. Had created for that. So it's very fascinating to see how precise we're able to be medically with the use of these magnets. And another field that these magnets are being applied to is actually infectious diseases. So you can kind of apply the same diagram that we saw with the vascular tumor removal, in that these robots have been tested for localized antibiotic delivery to biofilms and infections, especially in systems where antibiotics are not able to penetrate as well. Chen et al. Actually developed a magnetic hydrogel robots that can actively deliver these antibiotics to the infection site, and we can use the magnets to enhance bacterial killing. Okay. So I'm sure the question that you all have now is, are we in the midst of a new era of kidney stone treatments? I mean, with the use of these magnets and the robots, can we finally apply these to patients and give them relief with these magnets? And the answer is yes and no. Unfortunately, the treatment hasn't yet been used on humans. This research is still preclinical. So it's been tested in a 3D printed model, not yet in live subjects, except for the study that we saw, the porcine subjects being used. I believe it was with Zoe et al. But with the other subject, it's just been preclinical in 3D models. And of course, safety concerns still do remain, such as potential micromagnet coating toxicity, as well as behavior in physiological conditions like the flow of the urine, as well as the movement of the ureters. For affordability, of course, looking at it from an equity standpoint, it's unfortunately not affordable at scale, but the materials itself are inexpensive. So if we were to translate it clinically, the expenses would likely resemble other magnet-guided systems rather than other high-cost implantable devices such as cardiac catheters and cardiac pacemakers, for example, which of course we know are very expensive. Further work is of course still needed in clinical application, including larger animal studies and more refined control and imaging systems, just to be as precise as possible with the procedure. So the overall takeaway is that while this is still preclinical, I think this work demonstrates how these magnetically guided systems can enable more precise and minimally invasive kidney stone treatments. And hopefully with further validation, this platform can represent a more meaningful shift towards targeted patient-centered management for those who suffer from kidney stones. And yeah, I believe that's the end of the presentations or the presentation. So if anyone has any questions or any opinions, ideas, I'm very happy to answer or to hear them.
Thank you, Dr. Sarah, for excellent presentation, and you made it seems like the future is here. So thank you.
Thank you, Dr. Nadir. Yeah, the future is indeed very near, inshallah.
Yes, almost there.
Hello everyone. I want to say thank you to Dr. Sarah for her amazing presentation and the relevant topic. Since we are talking about kidney stones, I've read a recent study from the University of California. They found that even the kidney stone, we believe they were kind of not related to bacteria or infection. There is a bacterial core inside these stones, including the calcium oxalate, the most common kind of renal stones. And that might be the plausible explanation for why patients are getting septic after their kidney stone has been removed, either with the trypsy or with any other kind of kidney stone removal. That's all I know about this topic, and I am asking for more elaboration on this because I find it interesting. If someone else had a more depth view into this topic, I would be more than grateful to hear from them. And thank you all for the interesting topics we discussed today. Thank you.
Yeah, it's very interesting, that study that you said you read
Yeah.
from the University of California. It's my first time definitely hearing of the kidney stones having a bacterial core. I guess
Yeah, I
in an
know.
infectious perspective, I thought that, only the magnesium ammonium phosphate stones were the main ones that
All
would
of
cause
us
infections.
thought
So
that. Yeah,
Mhm.
it's
Yeah, so it's very
interesting.
fascinating. Yeah.
Yeah.
Patients getting septic after removal, you mentioned that, and I I kind of just assumed that it was either, due to the kidney stone causing urinary stasis, and then of course after the
Hmm.
procedure, possibly being due to the procedure itself. Um, so yeah, I think it's definitely something that's worth doing more research on. And thank you for sharing that with us. definitely a new perspective that I'm going to
Yeah,
search more
I
on after this, inshallah.
Yeah, we can possibly make a presentation about that at some time, like when we got more info to this. It's just the beginning, like, and I'm sure there's gonna be more researches done on this topic because it's quite fascinating, I guess.
Sure.
Yeah, absolutely, inshallah.
Inshallah. Thank you once again. Thank you, Aisha, for sharing the point.
Thank you, Renata.
If there is no more questions, we can move on to the next part. So any updates, anything you want to share, new ideas? And I'd like to welcome the new fellows, Dr. Sara and any new fellow. Welcome to the program. If you have questions or you can ask or you can reach out to the seniors in the program. You have the WhatsApp group or you have your team and team leaders, maybe they can answer. I want to share with you that there are a couple of conferences that they are either accepting or they will be accepting abstract or submit. You can submit to them. One of them is the cardiology or cardiovascular disease. So they are interested, and I think the window is open for submission, as well as Royal College of Physicians. We have, I think, in the coming weeks, an opening also for submission for the North America Primary Care Conference also. That will be in the near future. So if you are interested in writing some abstract or submitting cases or something like that, you can look into these options. You can click on it and it will provide you with a link and more information. I can share with you in the chat that I tried to get 5 ideas for the Royal Conference. That would be in UK. So if any of you is interested, I can share with you what we did so far. So this is a website where you will land, and these are just 5 ideas for projects. This is how you want to read about what you can do as international medical graduate. So the first topic will be about telemedicine in nursing homes. If you are interested in geriatric, for example, internal medicine, family medicine, this might be an interesting topic for you. The draft for you is as listed, so it's going to be a systematic review. And what you need to do is you want to go to these websites, use certain searching keywords and collect whatever studies done, and you can list your eligibility for the studies to be included, the duration and language, for example. After you collected all the studies, you can analyze them and use a sheet, for example, Excel sheet or Google Sheet to list and document your findings and summarize each study. So the results will be listed as how many studies you found and each study how many resident or subject and the total of them. And then see, you can modify this according to what's found as a result. Then you modify the conclusion. So this is one of the topics. This is the extraction table. So the author, the year, and so on. This is an example of how you search, for example, PubMed. And if you click here, it will show you the sheet. This sheet where it has a title, you can modify the title, guys. The abstract, the what that was shared with you just now. And here's the method, for example, the keywords, how you search, and these are the title or the menu where you'll find it. It's going to be in this area where you will have the study ID, author, year, country, and summarizing whatever you find. So again, and this is what you need to do if you are interested in this topic. These are some of the steps. The authors, you can add your name, email, country, and your role might be you want to be the leader for this topic, or you just want to be a member in this team, or you want just to be the submitting and contacting author. So you can just add your name, add the role, and your contact information here. So this is the first project about telemedicine in nursing homes. There is another one about clinical documentation tools and safety as well. So you can use this as another one. This is using AI in documentation. So you can also, if you are interested, can join Dr. Lina. She is interested in leading this project. So you can just add your information and contact her. Same with the second or the third one, which is about hyperkalemia in obstructive uropathy associated AKI. So you can do the same. The fourth one about reducing readmission from nursing care center or skilled nursing facilities. And it's going to be the same. You're going to be just reviewing some of the studies, and it's a systematic review. The last one will be about teaching clinical reasoning to, for example, international medical graduates. And this is how you will do that. And all of them will have what the next steps you want to do and the data that you want to collect. And here's the author list. If you are interested, you can have the role that you think you want to. Each one of these is listed in the website I shared with you. And if you are interested, you can be the leader for any one of these, or you can be a team member in any one of these, and you can participate as in many of them as you would like, or if you have time. If you have questions, please let me know. These are just ideas, and the American or the Royal College will be, I think, in May. So we have, I think, until March to submit. The other option is to work on some of them, and if you don't meet the deadline, you can wait for the North America primary care or other conferences. For example, there is the Internal Medicine Conference or ACP conference and so on. So any of these topics, or you can create your own topic. It's going to be the similar idea. If you want to do a systematic review, you work as a team from any country from your home, you can just work on that and create an abstract that can be submitted, and hopefully it will help you in your future. Any questions?
I just had one question.
Yes, go ahead.
Oh, sorry, تفضلي عايشة.
Oh, no problem. Just asking about the website that you show. Can you share us the link?
It's in the chat. Did you see it in the chat or no?
In the chat. Okay, yeah, okay, thank you.
Sure, yeah. Oh, page not found. Okay. Let me try to send it again.
Oh, okay, yeah. It
Is it
shows
working
now.
for you guys? Okay.
Yeah.
Okay, so you can add your name, your contact information. If you want to be the leader, you can go ahead. And if you want to recruit or you want to ask other fellows in the WhatsApp group to join you, if anyone interested. We prefer the number to be less than 10, 9, because some of the conferences might have limitation of the number of authors when you submit. They may have 10 or less authors, unless it's a big study or something like that. So for poster or for abstract, I think the number should be less than 10. If you have question, please let me know.
Are these
Thank you.
conferences held online or in real life?
So most of them nowadays, they have two options, one in person and the other option online. You can read about or see which conference you are interested in. If they offer the virtual option and you don't want to travel, that might be an option for you guys. The other option is to locate the conference where, in this case, the Royal Conference will be in England. So if there is a fellow from England who is interested, that fellow might be able to attend in person. And it's going to be just the cost for registration, maybe travel or so. And then the group will share if they are able to cover the cost. Unfortunately, we don't have funding from the program here, but this is traditionally what they did in the past. The fellows in this program, they choose someone who is near a conference if they want to go there in person, and then they share the cost for the hotel or the registration, and that fellow will go and present. Sometimes they can present more than one abstract, if that makes sense. Thank you.
Yeah, okay, yeah.
معلش دكتور نادر, I just had a question
Go ahead.
about the research project itself.
Yes.
What's the typical timeline for projects of this magnitude?
So it depends. You can contact also some of the fellows in the WhatsApp group who did the research as far as systematic review, for example. So it depends on how many fellows in your team and how big is the topic or the results that the studies that you can find. So usually what they do is they divide the team into either 2 or 3 people to do one task and move on. And I think within a month, it should be doable to finish a project like this. Sometimes you may take longer or shorter, depending on how aggressive or how available the fellows in the team. They work to get the studies and analyze and summarize and then come up with a conclusion for each. And then you can put your results and put the discussion. So, and now with the use of AI, things might be faster, if that makes sense. Thank you.
Yes, it makes sense. Thank you. I wanted to ask about like analysis also. So you mentioned that the bulk of the studies are systemic reviews and like meta-analyses, which I know like have more meticulous analysis. Would we be required to do that analysis as well, or are there like data analytics?
The easier one of systematic review and the other, I think systematic review is it's like straightforward. You don't have to do the analysis on the graphs and the extra steps. There is a format or like a tool where you just put your findings, like how many studies you found, how many you excluded, how many you included, and so on. So this is one graph for all systematic review that can be used, and I don't think you will need further analysis unless you want to just document there is no bias. If there is, for example, some of the fellows working with you read a study, usually they will be read by two. One of them will say it's a positive and the other one may say it's a negative effect or something like that. So if there is any difference, then you can ask a third person to review and then cite with either one of them, something like that. So there is a way of handling that as well, but it should be straightforward. Thank you.
Okay, thank you, Dr. Nadia.
If no more questions, I'd like to thank you all for attending this meeting, and thank you all presenters for great presentations, excellent ones. Thank you, Dr. Malaz, and your team for working and moderating this excellent meeting. Thank you. Also, I'd like to thank those who will come and watch the recording in the future. Thank you in advance. Have a wonderful day or night. See you next week. And if you have questions, please reach out and we'll be happy to help you. Assalamu alaikum.
Thank you, Dr. Ali.
Assalamu alaikum. Shukran.
Assalamu alaikum.
Islam.